Thank you, Dr. Clary. I'm Jay Doucette, the Division Chief of the Division of Trauma, Surgical Critical Care, Burns, and Acute Care Surgery. And today it's my distinct pleasure to introduce my colleague and partner, Dr. Amy Leppert. And Dr. Leppert is somebody who joined us in the fall of 2019. She had her start at Marquette University, where she did her undergraduate degree. She went to the Medical College of Wisconsin for her MD, and then she did her residency in general surgery at Utah. She was a fellow in surgical critical care at the University of Pittsburgh Medical Center, and then went to UW as faculty, where we were lucky to recruit her after a national search. Dr. Leppert has a number of publications in trauma and emergency general surgery, as well as publications in policy and advocacy. And she's also got publications in surgical education of residents and medical students. Dr. Leppert is our medical director of acute care surgery, and she's also program director of the American Association for Surgery Trauma Acute Care Surgery Fellowship, and she's the inaugural program director. That program just started this year and adds a second year to our successful surgical critical care fellowship under Dr. Godat. Dr. Leppert has done a number of things with the American College of Surgeons. She is a member of the Health Policy and Advocacy Group. She's a board member, has done that for 6 years now, and been a leader in the college in advocacy, which we know is an important step in academics. It's the thing that bridges our work and research, education, and clinical care to policymakers and politicians who make decisions that affect our surgical patients. Some other exciting things that Dr. Leppert's been involved with has been the development of an Egs Registry, and we heard about that last week at Research Rounds. It's my great pleasure to introduce her. Take it away, Dr. Leppert.
Some of the relative recent changes in clinical management places within a historical context of the surgical management, and something that I'm particularly interested in is the VARD. And then I'd spend some time talking about the role of a multidisciplinary team approach and some of the opportunities that we have available to us here at UCSD. So starting with just some basic facts for pancreatitis, it is not an insignificant disease process, as there's around 240,000 new cases per year. This puts it on the level of new case diagnoses for breast and prostate cancers as an example. However, only about 5% of pancreatitis cases will advance to necrotizing type. That puts it at about 12,000 cases, but it is not an insignificant disease process from an economic viewpoint, with most recent numbers looking at around $3.4 billion to the healthcare system just for diagnostic and treatment costs per year. This is also a disease process that will give you 2 opportunities to die if you are affected by it. Folks who have necrotizing pancreatitis can really succumb to multi-organ failure early in their disease course within the first few weeks. And once they make it through that, they still can suffer from severe sepsis, overwhelming sepsis, and multi-organ failure that also has an increased rate of death at that time. However, mortality has decreased in general over time from a mortality rate back in the 1960s of 65%, coursing down now to the range of 15 to 20% in severe or necrotizing pancreatitis. And this is really due to 2 major advancements that in critical care medicine and understanding treatment of severely ill patients, but then also from a surgical perspective, recognition of optimal, which would be delayed timing of debridement for those patients who do need to be debrided. Whereas historically, with those really high mortality rates, oftentimes patients were debrided at the height of their disease severity, and this became overwhelming for the physiologic system and resulted in death commonly. So how the heck did I get interested in this? And it really did start for me when I look back to my time as a medical student at the Medical College of Wisconsin. I rotated as a sub-I on the transplant service. And one of the greatest sort of impressional memories, maybe one of my first cases I did, was a pancreas transplant that had required multiple debridements. And I just remember being so impressed by the grossness of it, and hence the title of this talk. It was just left a great impression on me, how the body can go through such severe disease. As I transitioned into my residency, it seemed to dog along with me that this question of pancreatitis would arise. And so as a junior resident in the surgical ICU, I saw a small handful of patients come through with severe disease in various stages, a couple of patients who underwent open necrosectomy that ultimately ended in their demise. But around this same time, patients were being sequestered on the medical services, and there was a lot of discussion about non-surgical management. And I was seeing this concurrently at the time of people dying from really severe disease. And I remember having discussions about, with some of the, especially older surgeons who were annoyed by patients not on the surgical service, who were just getting FNA and biopsies, thinking they're going to convert sterile necrosis into infected necrosis. Small drains were being put into thick dead tissue, which didn't make sense to surgical dogma. And then later in my residency, as I was taking care of at the Intermountain Hospital System, actually a patient with severe pancreatitis who was on the surgical service, but still being managed with drains, the Dutch Step Up or Panther Trial results were published in 2010. I reviewed that and presented that at a journal club and tried to convince some faculty to let me take the patient for a VARD, of which of course I had no idea what that undertook, and we didn't proceed with that, but that was a very interesting concept to me, and I was curious of what the Dutch were doing across the pond. And then I would describe what is the ugly when I went and did my critical care fellowship in Pittsburgh as a surgical intensivist and part of the critical care training. Whenever we were on call, we were on primary airway control for the entire hospital. And so we would respond to all the rapid responses or any decompensations in the whole hospital. And one of our most dreaded and common calls was for patients in SIRS or sepsis that had undergone the newish procedure by the gastroenterologists who were doing endoscopic cyst gastrostomies with small stents and probably not enough adequate drainage at that time. For the most part, they weren't using large stents such as Axios as are used now. And these patients would get quite ill. Generally, they didn't need to be intubated, but it was quite disruptive to our nighttime calls. So I became sort of not a fan of the endoscopic cyst gastrostomies, although there is definitely a role for them today. Another interesting thing that occurred at that time, I was rotating in the transplant ICU, and it was large enough that there were 3 fellows in the transplant ICU at any given time, and there happened to be 3 of us surgical fellows there. And one of the medicine attendings went around and asked each of us newly graduated general surgeons how we feed our pancreatitis patients. And interestingly, he found that all 3 of us who trained at different institutions across the country fed our pancreatitis patients in a different location. One was stomach, one was post-pyloric, one was post-ligament of Treitz. And all of us were willing to die on our cross, saying that that was the right way because that's how we trained. And so clearly there was a lot of dogma that was still within the treatment of pancreatitis. When I arrived at the University of Wisconsin and started rounding on our emergency general surgery service there, I was seeing late consults for really advanced pancreatitis disease occasionally. And as I got to know my interventional radiology and gastroenterology colleagues, found that they were being really quite aggressive in both drain placement, management, multiple drain placements, and endoscopic debridements. And it seemed to me as I started paying attention to those patients that they had very prolonged courses and multiple procedures. And so again, reviewed the literature on the Panther Trial, Step Up, and VARD, and started discussing with my colleagues. And we founded the UW Pancreatitis Multi-D program. And what we found is if you build such a program, the patients will come. It takes some time, but we started seeing a lot of pancreatitis. And I always found it important, as supported in the literature, that surgeons really need to be involved in these patients from the early stages so that when and if they get to a point of debridement, they're optimized for a surgical procedure, and that all of the preceding procedures optimize the outcome of the patient. And finally, most recently, I came here to UCSD and have had some great fun in working to redevelop such a program here. And so that is my introduction to the gross, the bad, and the ugly, which I'm hoping to turn into the good, the bad, and the ugly. So I spend a little time going through a couple of cases that have been quite helpful to me as I've learned this process and gotten a bit more clinically acquainted with it. This was my first index case from a number of years ago in 2016. It's a 55-year-old female, previously completely healthy, living her life, who presented with gallstone pancreatitis that turned into necrotizing pancreatitis. She was decided for interventional radiology drainage before surgery was involved. And after quite significant period of time, this drain was upsized. She suffered from a portal venous thrombosis and continued to suffer from failure to thrive and ongoing infected necrosis. And therefore, after great discussion, we had a multidisciplinary agreement to proceed with a VARD, or retroperitoneal assisted, VO-assisted retroperitoneal debridement, which I'll go into further later. So this was her one of her initial CT scans. You can see some necrosis of the head of the pancreas and some fluid surrounding it. This got much worse, what I would call the bad, and ultimately the ugly. And that is the pancreas with a fairly large bore retroperitoneal drain within it. But you can see there is a lot of air and solid material. And while she had a lot of fluid draining from that drain, she sat like that for a very long time and just was miserable and was unable to leave the hospital. Once we decided to take her to the operating room, these are some intraoperative pictures of just from her anatomy marked. You can see her drain was placed quite posterior. I used a ultrasound device to track the pathway of the drain so that I could use that. Because it was so retroperitoneal, I was going to have to rendezvous, which is a little bit difficult in these tissue planes. So the patient is bumped up. The entire flank and abdomen ends up getting prepped in. And this is actually what I was able to take out of this patient, which is a little less than ideal. I'll show you some other more ideal necrosectomy specimens coming up. But this woman had had her necrosis so dehydrated and fibrosed that seemingly a cast of her pancreatic space was come out in one fell swoop. I'd prefer not to have that experience again because it was quite dramatic and followed by a pretty seeming cascade of blood, probably from a torn splenic vein or branch, which we were able to control with direct pressure. But it also had interventional radiology on backup, again, with a multidisciplinary approach. However, we were able to control her hemorrhage and she did just fine. This was my slightly senior partner, Dr. Anna Rourke, who worked with me on this first process, and we were quite proud of our specimen once we were able to successfully get her on her way to healing. There's been a ongoing case here at UCSD that many of the residents, anyone who's been on service with us at Hillcrest will readily recognize, and I appreciate everyone's help in the care of this patient. He is a 32-year-old male who presented last fall with alcoholic pancreatitis to another hospital. He was quite ill in their ICU. He underwent a tracheostomy and actually an open PEG tube placement for somewhat unclear reasons, with a fairly large upper midline incision. He ended up having some hemorrhagic conversion, either secondary to that PEG placement versus anticoagulation that he was placed on for a portal venous thrombosis. And ultimately, he was transferred to UCSD approximately 1 month into his course. Shortly after his arrival, he did have a nice drain tract in his retroperitoneum, and a retroperitoneal drain was placed. By this time, though, he was quite severely malnourished. This large hemorrhage within his pancreatic bed was pushing on his stomach, causing a gastric outlet obstruction. He had extensive necrosis throughout his gutters, extending down into his pelvis. And so our first maneuver with him was to really do an endoscopic debridement to try to decompress his stomach and duodenum and get him back on some enteral nutrition. These are his CT scans from the time he presented at UCSD. You can see here the actual G-tube that he had placed, which is stuck within this squash stomach with an area which appeared to be somewhat acute hemorrhage, and then extensive necrosis in his retroperitoneum. This is a representative slice after Dr. Kwong of gastroenterology placed an axial stent through a cyst gastrostomy with some decompression of this fluid collection. And this is a representative slice of his pelvis, seeing the large amount of fluid collection and necrosis that extended all the way down his paracolic gutter and down into his pelvis. So he was clearly a very sick gentleman by the time he presented to us. The left photo there is of the retroperitoneal drain that was placed. And because he was so far into his course, he was decided fairly quickly to go for a VARD, and this is post-VARD drainage. And you can see there's a clearing of the necrosis. There is still quite a bit of fluid contained. You can see just a slice there of my surgical drain. And you can see on the right photo there, the extensive fluid collection and walled off necrosis down in his pelvis that we then placed a IR drain later after we had his upper abdomen controlled. Now, this gentleman, due to his severe disease and probably underlying poor protoplasm from his alcohol history and general malnutrition, did suffer a number of complications and has had quite the prolonged course in and out of the hospital. One of the learning points on this patient, with the addition of placing the Axios cisgastrostomy stent, once I opened up his retroperitoneum, that opened up all of that space, and he had a prolonged retroperitoneal gastric fistula that did not resolve until the Axios stent and J stents were removed. But then that closed down quite nicely, and that improved his nutrition. He's had prolonged pelvic drains in place. Those have finally started to be removed, but he also did require a subsequent operation to do a left lower quadrant marsupialization, drain of necrotic and fibrous tissue. And also in the midst of his course, probably due to malnutrition, he actually developed some chylous ascites that self-resolved after a few drainage procedures and improved nutrition. Currently, to summarize his course, he is actually doing quite well. He is left with a small pancreatic fistula of relatively low output, controlled by one of his last surgical drains, which is all that he is left with. He is left on minimal antibiotics from some residual bacteremia, and he is on a course of antifungals. However, even though he had multi-drug resistant bacteria within his necrosis, he has been taken off all those antibiotics and done quite well since we have source control and removed the necrosis. He is quite deconditioned, but he is back to eating a regular diet, and he is now participating in his cares and is looking to transition further into his recovery with hopes to return home after some rehab. So when then does pancreatitis actually need surgery? In other words, when to mess with the dead pancreas? You know, one of the things I learned in my residency was to eat when you can, sleep when you can, eat when you can, and don't mess with the pancreas. So I didn't take that lesson very well, but I do prefer it when it is dead personally. But first things first, if we're going to work on a severe illness like this that is complex, we do need to have a shared mental model, particularly if we have desires to do this as a multidisciplinary team. And so for that shared mental model, we need to understand what disease we're working on. So the etiology, we must have shared definitions. We have to understand the severity of disease that we're working with. And then within the spectrum of disease, what exactly are we talking about for each individual patient? And then I believe it's important to have data collection registry to look at outcomes and to follow costs for these patients to make sure that the clinical decisions we're making are not only right for the clinical outcome, but for the total care of the system and the patient. So some of the basics then, in order to address the need to define etiology, it is important to make sure that you understand this is biliary, alcohol, autoimmune, or medication in nature. Hypertriglyceridemia is something that you see, but much less commonly. Occasionally, you can't figure out quite why the patient has pancreatitis, but it should always be considered that the patient has biliary etiology, because even without radiographic evidence, you can have up to 44% of cases on surgical specimens still have evidence of sludge or stones. And then, of course, the scorpions, and I understand those are only the scorpions from Trinidad as a piece of trivia. As far as the need to address common terminology, we're quite lucky in this disease process that this has been addressed a number of times over the years with the Atlanta Symposium and Atlanta criteria. First in 1992 with the Atlanta classification. It's important that we define terminology so that we can be clear as to what it is we're treating and help direct what that treatment is. It's important for categorization for study and registry, and it's important for multidisciplinary care for communicating between specialists and specialties to make care efficient and accurate. So there were some significant changes as folks got together to describe these things, and I encourage the trainees to update their terminology, although you'll see all sorts of terms still thrown around in radiology reports and clinical notes. In 1993, however, walled-off pancreatic necrosis, which is a bit more accurate description, was introduced. Not everything should be referred to as a pseudocyst, of course. In 2012, there were definitions and differentiations between sterile and infected pancreatitis, which really drives care, involvement of the surgeon, transient versus persistent pancreatitis, and of course, the spectrum of acute pancreatitis in general. Historical terms such as phlegmon, infected pseudocyst, persistent acute pancreatitis, and hemorrhagic pancreatitis really should be terms of the past and not used in vernacular today, as they really aren't specific or define what it is the patient is up against. This paper also established diagnoses, 2 out of the 3 features: abdominal pain, 3 times normal serum lipase, and imaging findings will define what pancreatitis is. There are 2 main categories of pancreatitis: interstitial edematous acute pancreatitis, which is just acute inflammation of the tissues, but there's nothing dead. What we're really interested in is necrotizing acute pancreatitis, so severe inflammation with either parenchymal or peripancreatic tissue necrosis. There's 2 phases, as I alluded to earlier: the early phase of 1 to 2 weeks when the patient is acutely inflamed and having an inflammatory response. And then later with persistent organ failure, persistent systemic symptoms from the pancreatitis. And this is when patients can get infected and have another course of sepsis. A couple of just standard images to review. This is necrosis of the pancreatic parenchyma itself versus here where the stars indicate normal pancreatic tissue with peripancreatic inflammation and necrosis, but with maintenance of normal parenchyma. We also have a need to define the severity of disease. Mild acute pancreatitis is generally not what we're interested in. Those are patients who come in, maybe are NPO for a day or 2, put on some clears, some bowel rest, and their disease resolves, and there's not much more to do unless they have worsening disease in the future. However, moderately severe pancreatitis and severe pancreatitis are things that we should be interested in. So moderately severe, there's no organ failure or there's transient organ failure and the patients are recovering pretty quickly. But the severe acute pancreatitis are those with persistent organ failure with 1 or more organs. And those are the folks that are at high risk for infected necrosis development. So severe acute pancreatitis then affects 15 to 20% of all pancreatitis comers. It is hallmarked by persistent organ failure. There is a need in these patients for critical care and ICU care, including advanced organ support, respiratory ventilatory support, renal dialysis. We really want to think about sepsis control and prevention, and that can be from antibiotics, which we'll speak about, or the lack thereof if possible, line placement, Foley management, etc. We want to optimize their nutrition, manage any pain, agitation, and delirium that they may suffer from. And this is a great opportunity for multidisciplinary care input from gastroenterologists, radiologists, and surgeons. And it's incredibly important to remember that moderately severe pancreatitis can progress to necrosis and infected necrosis. We also need to have a way of categorizing these patients. The ABSITE is coming up. Ranson's criteria is a oldie but a goodie to make sure you understand for characterization of who is sick. A little less clinically applicable but useful for research purposes, Apache 2 in the ICU. The SOFA score can also be used, and then for radiology scoring, there is the Bultholzer score as well. So it's just sort of a general overmap. We want to, again, highlight what pancreatitis we find to be most interesting. So we need to diagnose the pancreatitis. We have to have an assessment of the severity. And once we know it's severe, acute, really manage those patients carefully in the ICU as necessary, manage their medications, manage their nutrition. and then really watch for necrosis to develop. And if necrosis develops, this slide says prophylactic antibiotics. I'll argue against that. But then look for clinical deterioration and look for infected necrosis, which would be the defining factor of which patients need to have debridement. So then the current state of treatment, the improved medical management of pancreatitis, and the current state of surgical management. So overall, the prognosis for necrotizing pancreatitis has greatly improved over time, and that's again due to two major changes: the advancement in critical care medicine and techniques, and delayed operative intervention. Again, early on in the disease course, we will see respiratory failure and other sources of infection, but after 7 days, already sepsis increases, causing multi-system organ failure and can cause death. Interestingly, along this time course, and particularly after 2000, as these medical advancements, there was also a change in surgical landscape with the introduction of acute care surgery, emergency general surgery services. And Dr. Spain gave a great grand rounds earlier this year in talking about the evolution of that practice, which has also overlapped with my training, which has given me the opportunity to really become interested in this disease process. But again, critical care, I can't underestimate how critical it truly is. These patients can get very sick, and they need management of their respiratory system, which oftentimes will fail due to pulmonary edema, pleural effusions, reactive from the pancreatitis, and they oftentimes will be in shock. And it's a bit of a difficult management for their fluid resuscitation, and you're stuck if you over resuscitate them, and you're stuck if you under resuscitate them. So in the setting of under resuscitation, these patients will suffer from mesenteric ischemia, you'll worsen kidney failure, and you'll worsen their multiple system organ failure. However, if you over resuscitate them, you may precipitate abdominal compartment syndrome, necessitating a emergent operative intervention. You can have reperfusion injury, and over resuscitation will drive inflammation, SIRS, coagulopathy, acidosis, and multi-organ failure as well. So these patients really must be monitored physiologically closely. You have to keep a close eye on their end organ perfusion, their intravascular function, and their cardiac function. It is important to beware of sepsis prevention, which is tightly linked to nutrition, making sure that the gut is fed to maintain the mucosal border in an attempt to try to prevent bacterial translocation. And you really want to be a good steward of antibiotics at this standpoint. Just because people are severely inflamed does not necessarily mean that they're infected, and all antibiotics need to be directed at what the source of their infection is, if an infection is found. And then, of course, basic ICU principles of pain, agitation, and delirium management are paramount as well. Diving into some of the nutritional characteristics, there is actually some pretty good evidence and data about nutrition in these patients. This is a Cochrane review with 8 trials that showed enteral nutrition will reduce the risk of death, multiple organ failure, systemic infection, operative intervention, and length of stay. So whenever possible, these patients really need to have enteral nutrition in any way possible. Orally, if at all possible, if they can't tolerate that, feeding the stomach with a nasogastric tube. If they don't tolerate that because of symptoms, advancing the tube and trying to feed their small bowel directly through a nasojejunal tube. And only if they fail all those should they be transitioned to TPN. And even if possible, to do some trophic tube feeds while on TPN would be ideal. This is another study looking at 146 patients. It was a randomized study looking to feed patients when they felt hungry or versus when all of their clinical symptoms and their labs have resolved. I was trained initially to never feed a pancreatitis patient if they had pain, if their lipase was elevated. But this does not support that. If people are allowed to eat when they feel ready to eat, they have a shorter length of hospitalization. They have less opportunity for malnutrition and less fasting, obviously. And so I think this challenge definitely one of the surgical dogmas I was raised on. Prophylactic have had a lot of controversy over time, but I think most people that you speak to and the literature would support a consensus to avoid prophylactic antimicrobials whenever possible. And really this is because these patients are going to have a prolonged course and generally take some time to get infected, it's best to not select for resistant bacteria. And so when prophylactic antimicrobials are used, you do see a change in your infected materials. Resistant bacterial infections, of course, increase your length of stay, reoperations, readmissions. And while this precedes my time, I understand that UCSD has quite the significant history with such a case here. Therapeutic antimicrobials, of course, are a different thing. If patients are infected, they need to be treated, but they should really only be started in the presence of severe clinical deterioration. Sometimes it is difficult to tell if this is actual infection of the necrosis and can take time to figure out, and the patient can get quite sick. You may want to consider sampling the collection for speciation. Imaging to suggest air within the necrosis would be suggestive in the clinical setting of infection. But if they're not infected, what else could be causing their clinical decline, especially early on? The systemic inflammatory response syndrome. And this is something that can be really difficult to not want to treat. They will have fevers, they will have a high white count, they will be hypotensive, but that doesn't necessarily mean that they're infected. And so that's just a word of caution, and needs to be a thoughtful discussion about continuation of antimicrobials once they're started, particularly early in the course, or to decide what it is you're actually treating. Moving then to operative intervention. This has an interesting history, and when we talk about that really high mortality rate, this is oftentimes, I think, what happened, and this is what I saw as a medical student in some of those transplant patients. There were recurrent pancreatic debridements, and really it became a pancreatic stoma where there's just a hole to the pancreas and there's just more and more dead stuff and goo. And so this really is the gross, right? There's not much goodness in that picture. It's hard to tell what anything is. And this requires, lots of resource utilization, lots of trips to the operating room. You can't really tell what's alive and what's dead. It's just massive inflammation everywhere. And so the surgical dogma, again, remove what is dead, drain what is infected, but it's hard to do that if you can't tell what is what. So over time, there's been a number of studies, and I just wanted to touch on a few of them over time. I thought this older study in the 80s and 90s talking about delayed operative intervention being safer was really quite impressive. Incidence of operation from 68% to 33% from early 80s into the 90s, with a drop in mortality from 40% to 12%. That's really stark, and really, I think, set up the basis of surgeons saying, hey, we're just hurting people by operating, let's not do anything. And I think the pendulum may have swung a little too far. But there was another study, declining morbidity and mortality in surgical management of pancreatic necrosis. So the decreasing length of stay and decreasing mortality with choosing the right time to operate. This is a randomized controlled study looking at early versus late necrosectomy, and the late wouldn't be considered late today, but they looked at necrosectomy very early on in the course versus after about 2 weeks. They found just in this time frame, by allowing that inflammatory response to cool down for a little while, interventions and mortality decline, there's less blood loss. And those really early operations just do not interrupt that inflammatory response and probably only propagate it to be worse. So you really want to try and actually hold out for 28 days in the more recent literature to let that SIRS settle down. However, it's not always possible to avoid an operation in the early stages, and therefore early focused operative intervention should be considered. And that is where the operating room is exclusively directed at the ischemic organ, with, if you're in the belly, avoid the pancreas. So what would make you to be in the belly? Ischemia of the gallbladder or colon, for some reason a small bowel perforation, or if the patient develops abdominal compartment syndrome. And I can tell you, it is very hard to open someone's belly for compartment syndrome and see nasty sort of pancreas that's begging to be debrided, and leave it alone. But it really is important to leave it alone and just take care of the problem you're there for. So timing of operative intervention should really be beyond 28 days and avoid open abdomens and avoid the recurrent pancreatic stomas. Operate only if you have another indication to operate and deal only with that issue. Avoid pancreatic debridement just because you're there anyway. There's a lot of different intervention options, though, of course, for just debridement and drainage. Percutaneous drainages can be used. You still can utilize open surgery. Laparoscopic approaches can be done both transperitoneally and retroperitoneally. Gastroenterologists can do cystgastrostomies and necrosectomies in small volume. Any one of these things can be done alone or in combination, which often becomes the case. And of course, the percutaneous drain step-up procedures with the minimally invasive VARD, endoscopic transluminal necrosectomy, gastrojejunostomies, and fistula jejunostomies have also been described. So how do you pick which is the right to do? A lot of it depends upon patient anatomy. Where is the dead tissue? Is it something you can get to from the retroperitoneum, or is it all stuck over by the pancreatic head? It depends upon your surgeon, interventional radiology, interventional gastroenterology experience and willingness to participate. Sometimes dependent upon your hospital resources, access to the operating room and other adjunctive services. But this really does require a coordinated effort and a multidisciplinary approach. The percutaneous catheters, when placed, really need to facilitate subsequent surgical access if that becomes necessary. And again, the location of the necrosum often will determine the approach. And having various opinions as to what can be approached in what manner is very useful. Every intervention, of course, does have its limitations. So percutaneous drainage, as we saw in my index case, really cannot remove the thick, solid necrosum. And one of the things clinically I find is these drains will put out very large amounts, and there's a lot of fluid that the body creates trying to flush out this necrosis. But once it's so solid and fibrosed, it won't come out. And so folks are always impressed in the operating room by the amount of material that's left behind, even though there's large drain outputs, seemingly like they're working for a regular abscess. With endoscopic cystgastrostomy, they can also have difficulties removing the very thick and solid necrosum, and to do so often requires multiple procedures over a very prolonged period of time, which is a huge investment for the hospital system, the gastroenterologist, and of course the patient whose life is being interrupted by this horrible disease process. The video-assisted retroperitoneal debridement, of course, requires a general anesthetic. There is risk of occult bleeding and organ damage that can be difficult to control, and it does require a flank incision. And then, of course, there's open laparotomy drainage that, done too early, can really exacerbate death. And even if done in a delayed fashion, which is sometimes necessary, does result in a longer recovery. Important to keep the goal of necrosectomy at hand, which is the targeted removal of infected necrosum in the most minimally invasive manner possible with broad drainage to get source control. And that brings us to the Panther Trial, which the results were published in the New England Journal of Medicine in 2010. This was a study in the Netherlands of adults with infected necrotizing pancreatitis. It was a randomized study between open necrosectomy and the step-up procedure. However, the patients were randomized after there was a consensus agreement for a decision for operating room. Patients all had 4 weeks of ongoing disease by the time that decision was made. The step-up procedure, as they described it, was a left retroperitoneal drain placement, and within 72 hours, if complete resolution or clinical improvement was not met, that drain was increased. And again, at 72 hours, if that didn't resolve all of the collection, the patient progressed to VARD. And so what they found is in their intention to treat study, 45 patients received open laparotomies, and 19 of those required repeated laparotomies and drainage procedures, and 15 other patients required percutaneous drains postoperatively. So even though a maximally invasive debridement approach was undertaken, that didn't resolve everything from the patient, and they were still committed to drains and additional procedures. 43 patients were in the step-up procedure. Interestingly, around 35%, a third of the patients resolved with just one drain. So a small bore drain, that the fluid and pus under pressure just being drained like an abscess was actually enough, and the patients didn't actually require any additional procedures. I think that was surprising to most people. It's still surprising to me that patients that I'm convinced I'm going to get to do a cool operation on get better, which seems inconvenient for me, but really in the best interest of the patient, which is most important. Of those step up patients, 26 of them received a necrosectomy. Most of them were VARDs, so about 33% of the patients required a VARD drainage procedure. Clinical endpoints that they found, major complication and death was reduced in the step-up procedure to 40% versus 70%. Clearly, this is still a sick patient population, and so there is still a lot of complications that need to be dealt with, even with a more minimally invasive approach. As far as utilization and costs, there was less postoperative ICU care required in the VARD group significantly, and there was a relatively significant decrease in cost, and these are cost numbers, so 16,000 decreased costs at 6 months for the step-up procedure. So take-home points from this paper really changed the conversation of the management of necrotizing pancreatitis. I think especially in this country, it gave us a different perspective of what can be done and that there are surgical options. The necrosis can partially act like an abscess with a fluid collection, and you may be surprised more often than you think that just by draining it, you will get resolution and not have to progress to surgery. There's less inflammatory response in the step-up procedure, and it's useful to wait those 4 weeks. It does require commitment of surgery, interventional, and GI in a multidisciplinary fashion. And it really probably allows you to maintain viable pancreatic tissue. Patients were found to have less need for pancreatic enzymes and diabetes for that. This was the Dutch Acute Pancreatitis Study Group publication on a VARD. You can see their retroperitoneal drain there on the left, and their patient seems to be much thinner and less edematous than most of the patients that I get to surgery. But here is their process, cutting down on the drain. They use a trocar to place a camera through their incision and use laparoscopic instruments for debridement. And here you can see them pulling a fairly large chunk of dead pancreas out through that incision. So these are some of the specimens and photos that I have taken. Again, that first sort of undesirable, very fibrosed, solid piece. But typically you find smaller chunks. That top right corner is all individual chunks, kind of in the position where they came out of some retroperitoneal debridement on the right side going down the gutter. And you can see the fibrous cavity there on the left. This is a patient in preparation for the operating room, what the setup looks like to have access. And I had a great pleasure in working with Dr. Ariel Lee. We presented this video presentation at last year's Clinical Congress. And this is a snippet for you to give you a bit of an idea of what this looks like in the operating room. So the incision has already been made. That's IR's drain left in place that I've followed into the cavity. And this is a piece of the dead pancreatic necrosum. You can see I'm slowly pulling on it, taking only what it gives me. I tend not to use a trocar for my camera and like to use a regular open ringed forceps, which gives me a much greater ability to take out large chunks of tissue. The incision in the skin is approximately 6 or 8 centimeters in this patient, but the breaking into the retroperitoneal cavity is only a hole of maybe 2 or 3 centimeters. And so I slowly work the tissue free from its inflammatory rind cavity internally. You can see there's a lot of fluid and purulence that's maintained. So despite a patient being a month out and consistently drained with very large drains, these are often 18 to 24 French drains. That's the collection of material that has been being removed from the patient. You can see it's almost the consistency of what's left over in the drain in your shower if you have to clean that out, which is, again, the gross part. The cavity is well developed at 4 weeks. And so you don't generally see any organs. You want to see just that inflammatory rind. You will get some inflammatory bleeding from that, but it often stops on its own with irrigation. I do use a laparoscopic suction irrigator, can sort of hydrodissect some of the tissue of necrosis. Here, it is not necessary to remove all of the necrosis, but clearly there's been a massive decrease in the amount of dead tissue removed from this patient. I will sometimes, for a bloodier cavity like this, place either, this was a Rixta at this time, but now I use Surgicel powder, just to kind of help that, again, that inflammatory ooze. And so this is a patient positioned in the operating room. You can see his previously placed RP drain. And then post-operatively, I've placed a couple of surgical drains, and just the relatively small flank incision of going through, just getting down into that necrotic cavity and debriding it. And then post-operatively, they heal well, the edema is gone, feeling better, walking, and getting back on with life. Of course, there are endoscopic treatments. I won't spend a lot of time here, but there have been randomized trials, and depending on how you look at the literature, patients do better here, claiming less inflammation with endoscopic debridements. However, there are negatives with endoscopic, again, with multiple debridements and prolonged course for the patient, although I think this is a good choice depending, again, upon anatomy and other various patient selections. And so it is important to have a good relationship with GI. A recent publication just out this month in the Annals of Surgery, again, talking about a meta-analysis that treatment for infected pancreatic necrosis really needs to be delayed and allows avoiding of an open surgical approach. So how do we then get to coordinated and cooperative care? I'd like to introduce the UCSD-Pancreatitis Multi-D Working Group. The first important part is to build a team, and I think our team that we built here isn't quite as ramshackled as this team is, and in no particular order, matching up with those famous folks. I've had a real pleasure to get to know and work with Zach Berman in interventional radiology. We talk frequently about patients, as well with Dr. Kwong, who I often, as COVID is resolving, have a chance to share some office, some clinic space with him to see patients together. In the multidisciplinary approach, the biggest thing is to do what's best for the patient. Understanding that upsizing of drains can result in clinical course improvement for the majority of patients and even complete resolution, and that is fine. If patients can do without surgery, obviously that's great for them. But if they need an operation, it is good to have an entire team assembled. And of course, some patients may not have anatomy favorable to surgery or to endoscopic debridement for any various reasons. And so choosing which is best on each individual patient is optimal. In reviewing Panther, I was really thinking how they actually defined a multidisciplinary approach. So while it was part of their research protocol for deciding operative intervention on patients, they describe having an expert panel, which is really a multidisciplinary group that consisted of gastrointestinal surgeons, gastroenterologists, radiologists, and they looked at case descriptions and CT images and made an individual and group consensus as to how patients should proceed with treatment. And so I think they did a really nice job of defining not only what procedure is better, but how to select those patients. So how then can we get there from here? Really, we just need to do it. So I've put a soft start on December of 2019 because of course that is right before COVID initiated. And so some of the development of a multidisciplinary group can be quite difficult in the midst of a global pandemic. However, we identified core folks of interest, myself within emergency general surgery, Dr. Kwong, Dr. Berman of GI and IR, respectively. And then also working with the medicine teams, the medical intensivists, presenting to the fellows so that they know that surgeons are here to support them in a complex disease process, working with the infectious disease folks to come up with a comprehensive antibiotic plan and to understand what the likelihood of debridement and removal of necrotic infected tissue is. Social work and case management are incredibly important as well. So the idea is that all core services will see the patient at the time of consult and coordinate a plan under specific areas of nutrition, antibiotics, anticoagulation, imaging, and debridement, and then to develop an outpatient care coordination when the patient is ready to transition. This includes frequent inbox communication, texting, phone calls, the multi-D clinic on Tuesday mornings, 2 times a week. But we have more development to do with order sets and consults and standardizing notes and plans specifically. Currently, though, there is a biweekly multi-D working group clinic that I will see patients in. Dr. Kwong see patients in. Dr. Berman is somewhat available, and others are welcome to join that on an as-needed basis. This is the first and third Tuesday mornings at the Hillcrest Onc Clinic on the first floor. Melissa Evans has joined our group, and we are so thrilled to have her, and she is helping us look after these patients as well as our other complex emergency general surgery patients. And that is a great benefit to us and to the patients. So again, we communicate on an as-needed basis. And at 4 weeks, we set to make a plan for intervention, what modality they're going to use. We'll again determine follow-up plan for when those patients transition to outpatient, how often they need to be seen and coordinated in the inpatient setting. And then outpatient care coordination, the whole team is really working on this, from the nursing coordinator, our clinic scheduler in the on-clinic, Mara Mendoza has been fantastic, and our surgery scheduler, Danielle Chandler, who has recently joined us, has been helpful in getting this organized so that we can have patients clearly know how to follow up. Future development will be a monthly conference to review active patients in the various stages that they may be in, with any residual complications if they need their gallbladder out at a later date. Developing standardized orders, standardized service consults on a standardized note template. So this is sort of an early phase 1 thing I've developed. It's UCSD-PANC Surge, which can be used by the residents to have a standardized and guidance to all the areas that should be comprehensively discussed and planned for on each of these patients. This will get developed into a drop-down menu or note template at some point in the future. And then this will also hopefully get adopted by GI and IR to have them have a standardized way of reporting, so we can all quickly know what each other is thinking, and all the other teams involved in the patient care can as well on a daily basis. Something that I had done at my previous institution and hope to do here, buy-in from both Dr. Kwong and Dr. Berman, that we would like to know about these patients as soon as possible and to consult each of our services. And so we should be able to build a order set into Epic, which would consult all 3 services with one order, simplifying the care for the referring teams or the teams that have admitted the patient. And we're interested in seeing any patients who are acute, complex, necrotizing, or otherwise, and you can see some things listed to the left there. So can it be done? I argue that it can, as I've been able to do it before. I built a registry in red caps previously, and in our multi-group consensus meetings that we held monthly, tracked over about 3.5 years, 108 patients. Not all of those obviously are surgical, only about 10 of those progressed to surgery, but we have that data. We are starting to collect this data here at UCSD as well. And I'm very excited about a project I've been working on with the great help of Tom Mao and the IT folks, which is a prospective EGS IT-based automated registry. And so this will fit nicely within that, as well as all of our emergency general surgery patients. There's a real-time discussion of patients, this monthly review, and then we have some needs of a dedicated social work and case manager, but having a shared clinic has been really a useful adjunct here. Probably a little short on time, but just real quickly, these are not in chronological order, but of the first 10 cases that I did initially, you can see some of the procedures. Many of the VARDs were done. Sometimes patients, you think you can do a VARD and you're not able to, and some of them were converted to open necrosectomies. Again, this isn't acute, and all these patients really did quite well. You can see patient listed as number 8 was a patient who had abdominal compartment syndrome and had numerous takebacks before his abdomen could be closed. And interestingly, after his abdomen was closed and his pancreatitis evolved, he did actually go on to have a VARD after having a prior decompressive laparotomy, and that really worked out quite well for him, and he did well in the long term. Just a little bit of data from that previous population. So a total of 108 patients in that left column. 9 here, or excuse me, 10 were included in the debridement. Almost all of our patients were male. Central Wisconsin is not the most diverse place, so it was mostly a Caucasian population in all of the groups. And here you can see some of our outcomes data. We started to put it together. We did have more readmissions in our operative group and more hospitalized days, but I think because we had a transition time of actually getting the program up and running, that by the time patients got into the operative stage, they actually already had prolonged courses, were actually quite sicker. So our population was sicker, and we would benefit from actually earlier operative intervention and closer management early on. Outpatient referrals is something that we're very interested in getting. I would prefer to get these patients sooner than we did in patient that I presented earlier. Currently, this is through the transfer center. So if there are folks that hear of that up at La Jolla and they're interested in sending that down to Hillcrest, we'd be happy to take those patients. And I'd like to do some future outreach into the surrounding communities to really support our referring hospitals who may not have the resources to intensely take care of these patients, so that we can provide that to our communities. And so is there any good to all of this badness, or is it really just gross, bad, and really ugly retroperitoneal goo? I think there's a lot of goodness. The patients are really sick when we see them. They don't have a lot of hope. They're malnourished, they're weak. But when that patient walks into clinic under their own power, feeling better, they're returning to their regular life. They're some of the most grateful patients that I've ever taken care of. They're incredibly relieved. And so of all the work, stress, and toil, it's the recovered patient coming back to clinic that really makes all of the work worth it. So just a few take-home points. Really wait for the necrosis to mature. You want to wait at least 4 weeks for any kind of drainage, unless you have to for sepsis control sooner than that. Antibiotics for clinical decompensation, but really try to avoid treating SIRS. Don't use prophylactic antibiotics. Nutrition is absolutely paramount. Figure out a way to feed the gut, in part, if nothing else. And the multidisciplinary approach is absolutely key, in my opinion. Utilizing the step-up techniques, avoiding open necrosectomies whenever possible, and including multidisciplinary colleagues to provide the best care possible for this complex patient group.
All right. Thanks, Dr. Leppert. I'll defer to our chair, Dr. Clary, for first question, perhaps.
Oh, thanks, Jay. Thank you very much, Dr. Liepert. That was extraordinary. I've taken care of quite a lot of these patients, and every time I would meet them, I would tell them or their family members that this is a one-year disease, and it really takes them ultimately a year to kind of, get over it. And clearly over the last, couple of decades, there's been a lot of progress, and you mentioned a lot of it, in avoiding early operative debridements. I think another component of, progress is really avoiding interventions unnecessarily in peripancreatic fluid collections. And, commonly as people are sick, they have peripancreatic fluid collections, and then that by reflex, people want to intervene in it. You showed that book, Perfect Predator, and I think I mentioned it last week actually in M&M conversation, but I am featured in that book, not entirely accurately, but what I think that patient's problem wasn't antibiotic stewardship when he was in Egypt and in Germany. I actually think his problem was early intervention from a GI perspective on a peripancreatic fluid collection that perhaps didn't need to be intervened in. And then he got Acinetobacter, actually from the endoscopy, from the endoscope. There was a rash of that going on in Europe at the time. And so one question I have to you is, what about the management of peripancreatic fluid collections, and how do we put the brakes on unnecessary approaches to that? That's my first question. My second question is, in your multidisciplinary team, it probably would be great to have someone from the ER. And because a lot of these patients, they come in through the ER. And so getting someone on your team who, number one, understands the triage to EGS, but also the early resuscitation. And so I think it actually would be helpful to have an ER kind of member of the team, you know, just in the spectrum of, you know, once they hit the door. And then my last question is folding this into a bigger pancreatitis multidisciplinary group that addresses chronic pancreatitis as well. Because I guarantee you, if you have both acute and chronic pancreatitis programs covered in a program, that you will, I mean, the floodgates, you know, will open in the region because it just doesn't exist. And I know Becky and Wilson have kind of been working on the chronic pancreatitis component of things, but maybe comment on how do we kind of fold this into an even bigger pancreatitis program.
Perfect. Thank you for your comments. I'll try and answer them in order. It's very interesting to me you mentioned the peripancreatic necrosis because, of course, I've encountered it before, but for whatever reason in the last year, that seems to have been my biggest bane here at UCSD. And a patient I didn't present, but got also transferred in, she had almost normal, total normal pancreas, but massive peripancreatic necrosis all the way down her flanks. And that had all been drained and all sorts of things had happened to her before she appeared here. And honestly, with just some good nutrition and minimization of interventions, she got better, and we're continuing to follow her. But I think you're absolutely right. Anytime you get into that peripancreatic tissue, and it's not just the pancreas you're debriding, I think you're in for trouble. The patient that I did present with all of that necrosis down into his pelvis, there's not a good way to deal with that. And if you do have to drain it, what I found in the past is normally you can drain it dry and it'll scar down and fibrose. In this patient, that didn't happen and we ended up having to go after it. But I was very resistant and waited a long time to do that second procedure to clean that out. But ultimately, that's what that particular patient needed. And I'm not sure what happened prior to his arrival here that caused that much. I've never seen that much necrosis down into the pelvis and extension into the pelvis. Usually you see a little bit and you can either get to it or, like I said, drain it and it goes away. So I think that's a well taken point. I don't think there's a lot in the literature about that I'm aware of. And I think it'll be, especially if we create a registry and follow all of the patients and not just the surgical patients, those are the kind of questions we can ask, follow, and report on. So hopefully more to come on that in the future. I appreciate your comments with the emergency department. I do think it might be a little difficult with how, we're really clinically deciding management once the patient is been in the hospital. But where I do take your comment to heart is just in all of the emergency general surgery system development. All of our patients, what makes our system different than other surgical divisions is we don't get a chance to meet our patients and develop a relationship before. For the most part, they come in, whether it's pancreatitis or perforated diverticulitis or whatever horrendioma they have, they come in incredibly sick and we develop a long ongoing follow-up relationship with them. And so the involvement of the emergency department is important in all of those patients and is something that is on my list. I hope with the pandemic calming down, we'll all have more resources and time to address that. So point well taken. And finally, the chronic pancreatitis, I didn't have time to include everything I wanted to. I would keep you all here all day if I could. Again, I don't know why I'm so interested in this, but it does get my feathers fluffed a bit. It's very gracious of Dr. White. She and I met early upon my arrival here at UCSD, and we had some very clear discussions that she was happy for my involvement in the acute pancreatitis processes. Of course, with my clinical practice, I have less interest in the chronic pancreatitis and the surgical procedures for that. But she has interest at Hillcrest, and I know others in the department do as well. And so one of the great things about having that Tuesday morning clinic is it's sort of concurrent, where we have the acute pancreatitis clinic as well as a chronic pancreatitis clinic. And by cohabitating outside of a pandemic, we'll be able to, in person discuss and transition those patients off. And so I'd be excited for a larger programmatic development.
Great. Thanks so much, Dr. Liepert.
All right. Well, thanks very much, Dr. Leppert. A fantastic talk and a lot of great work being done to look after what's probably a neglected disease. And I think you've definitely made the point that, severe acute complicated pancreatitis does require the involvement of a surgeon, and these patients don't do well when they're neglected, that's for sure. So thanks very much for your talk today, and look forward to hearing more about the program in the future.
Sounds good. Thank you.